Dear colleagues, the following slideshow aimed to introduce research from a group of Russian scientists led by Dr. Oleg Bukhtoyorov, MD, DRS, which was presented at the 4th World Gene Convention in November of 2013 in Haikou, China. The new data on the cancer disease development caused a particular interest in one part of the scientific society due to the discovery of the phenomenon of dependency of the activity of anti-tumor immunity to a higher nervous activity of cancer patients, as well as to critics from the other part of the scientific society representing the huge multi-billions lobby of cancer gene therapy. Moreover, we are describing the mechanism of cancer development in humans with the name cancer reparative trap, from a point of view unknown before. It is evident that the scientific world is on the verge of creating a new and effective cancer management process, which is however not associated with effects on the human genome. We hope that the data presented in this report will be useful in developing new approaches for cancer management in humans. The history of studies of malignant tumors has defined three groups of carcinogens taking different parts in the development of cancer, as well as identifying key mechanisms of carcinogenesis. On the one hand, there is the damage of the genetic apparatus of the cell, when the cell acquires the ability of malignant growth. On the other hand, there is immunosuppression, which leads to the violation of the supervisory functions of the immune system when malignantly transformed cells are not eliminated from the body. These two occurring processes form the basis of carcinogenesis. However, is carcinogenesis possible without exogenous carcinogens? Numerous studies have shown that there are endogenous carcinogens when products of oxidative nitrosative stress damages the DNA of cells and causes immunosuppression at the same time. Under what conditions is the oxidative nitrosative stress activated? Numerous studies have shown that such conditions can be created in the background of chronic emotional stress, leading to the disintegration of brain systems. In particular, the disruption of the functioning of the hypothalamic pituitary adrenal and sympathetic adrenal medullary axes. The ischemic and metabolic tissue damage, along with the formation and maintenance of chronic inflammatory lesions with high levels of reactive oxygen and nitrogen species, can damage DNA. The mentioned processes happen with the participation of stress hormones and cause immunosuppression. So it forms psychogenically, the necessary and sufficient factors for induction of tumor growth, also known as psychogenic carcinogenesis. In turn, the fact of the cancer disease is a chronic, massive, endless, inexhaustible stressor locking in a vicious circle of psychogenic carcinogenesis. Thus, cancer patients with psychogenic carcinogenesis are affected by double massive psychotrauma. In this group of cancer patients, the disorder of higher nervous activity leads not to a total compromising of the immune system, but to the selective suppression of specific anti-tumor activity in the immune system. This assumption is based on our numerous clinical observations which show that cancer patients suffer colds, bacterial, and fungal diseases no more and no longer than healthy people. Moreover, almost all cancer patients observe a normal or even accelerated healing of wounds, cuts, and scratches. It should be noted that the formation, development, and progression of the cancer process depends largely on the state of a specific anti-tumor activity in the immune system. In connection to what we questioned ourselves, are there any relationships between the higher nervous activity and specific anti-tumor activity of the immune system in cancer patients with psychogenic medical history? In order to answer this question, we decided to perform the following study. The selection criteria of cancer patients is shown in the slide. We have assumed that patients with psychogenic medical history belong to a group of cancer patients with psychogenic carcinogenesis. Therefore, these patients had common pathogenetic mechanisms of development and progressions of cancer. This assumption has allowed us to conduct a study of cancer patients in one group without dividing into types and stages of cancer. This slide represents the gender age characteristic of cancer patients, the structure of cancer types and stages, kinds of therapy, and time after surgery. Let me just draw your attention to that in patients with suspected psychogenic carcinogenesis, there are common mechanisms of development and maintenance of the cancer process, regardless of the histological type of tumor and the stage of the cancer process. Therefore, these patients were studied in the same group in spite of the generally accepted rules. The diagnosis of mental disorders in cancer patients was conducted clinically in accordance with International Classification of Diseases, ICD-10, and supplemented by psychometric data. We used the Symptom Checklist 90, Hospital Anxiety and Depression Scale, State Trait Anxiety Inventory Scale. The quality of life of cancer patients was evaluated using the SF-36 questionnaire. We used a delayed type hypersensitivity reaction as a specific immunological response for integrated assessment of specific anti-tumor activity of the immune system in cancer patients. We used a lysate of human melanoma cell line BRO as antigens for a DTH reaction. It is known that melanoma cells contain a broad spectrum of tumor-associated antigens, or TAA, represented in different histological types of malignant tumors. We used the minimum dose of TAA, which caused non-stimulated native DTH skin reactions. For instance, we used the dose 100 times less than the dose that was used in the study of anti-tumor vaccines, CancerVax, in the US. In our study, the peak of DTH reactions was observed 12 hours after the administration of very low doses of TAA. Assessing the level of specific anti-tumor activity of the immune system of cancer patients conducted in the expression of the DTH reaction. We examined the concentration levels of 30 cytokines in native plasma and 24 hours blood supernatants, the daily cortisol level in blood plasma, of cancer patients for the study of the mechanism of possible interconnections of higher nervus activity and specific anti-tumor activity of the immune system. It should be noted that in clinical practice there are no conventional techniques for comprehensive evaluation of specific anti-tumor activity of the immune system in cancer patients. In addition, the immunological specific DTH response to TAAs has been known for a long time. However, scientific and clinical interest to it has been lost, since numerous studies have shown that there are no relationships between DTH responses to TAAs, including non-stimulated native DTH skin reaction to TAA, and the cancer stage, cancer types, kinds of treatment, immunological indicators, gender, age characteristics of cancer patients, and other indicators. In our studies conducted on a group of cancer patients with suspected psychogenic carcinogenesis, we also found no relationship between non-stimulated native DTH skin reaction to the TAA and gender, age of patients, smoking, cancer stages, histological tumor type, time after surgery, kinds of treatment, 30 cytokines in plasma, and 24 hours blood supernatants of cancer patients. However, in these patients, we found a strong positive correlation of non-stimulated native DTH skin reaction on the TAA, with quality of life, and the inverse correlation with a number of psychometric indicators of mental disorders, especially anxiety. In this context, the clinical assessment of the higher nervous activity in these patients was of great interest. The clinical examination revealed a high level of mental disorders in this category of cancer patients, regardless of the cancer type and stage, type of treatment, age, or gender characteristics. The structure of mental disorders, according to the International Classification of Diseases, ICD-10, is on the slide. Mostly, these were anxiety disorders and adjustment disorders. Some cancer patients demonstrated organic anxiety disorder, which appeared after chemotherapy. Such a pathological condition occurring in cancer patients after chemotherapy is known as chemobrain. Taking into account the high rate of mental disorders among cancer patients with psychogenic medical history, as well as the close relationship between the native DTH skin reaction on the TAA with indicators of mental health and quality of life in these patients, the question is, what are the changes of non-stimulated native DTH skin reactions after the elimination of mental disorders in cancer patients? In order to answer this question, we conducted a drug correction of mental disorders for 90 cancer patients. Only 45 cancer patients agreed to participate in a further study. The characterization of these patients is shown in the slide. The main purpose of the drug correction was effective elimination of mental health problems using a variety of anxiolytics, antidepressants, and their combinations. Clinical experience has shown that the most effective drugs were diazepam, tianeptine, and venlafaxine. As a result of medical psychocorrection, the significant clinical effect has been achieved, which was confirmed by the results of psychometrics. As you can see on the slide, a significant positive change in almost all studied psychometric indices were shown. It is necessary to pay special attention to the substantial improvement of anxiety and depression indicators, which were measured by 3 different tests. This confirms the elimination of mental disorders and the anxiety-depressive spectrum, which are common in cancer patients. For 60% of cancer patients, the duration of psychocorrection ranged from 3 weeks to 3 months. For the remaining 40%, it required 4 to 6 months. The improvement of cancer patients' mental health was accompanied by a significant improvement of quality of life, mental and physical health, determined by the SF-36 questionnaire. As a result of mental disorder relief in cancer patients with psychogenic medical history, there was also a significant spontaneous increase of specific anti-tumor activity of the immune system as measured by DTH skin reaction on TAA. This increase in specific anti-tumor activity of the immune system in cancer patients is not associated with changes in the concentrations of 30 cytokines in the native plasma 24 hours blood supernatants and daily cortisol level. There was also no correlation between DTH skin reaction on TAA and the concentrations of 30 cytokines in the native plasma supernatants and daytime cortisol levels after the removal of mental disorders in cancer patients. At the same time, there was only one negative correlation between DTH skin reaction on TAA after the elimination of mental disorders and anxiety. So, the suppression of specific anti-tumor activity of the immune system in some cancer patients is psychogenically caused. However, it is also reversible. Presented research suggests that there is a category of cancer patients with psychogenically caused carcinogenesis. The clinical criteria of this category is shown on the slide. This is psychogenic medical history, psychogenic anamnesis, mental disorders, and suppression of specific anti-tumor activity of the immune system. It should be particularly noted that patients within this category have suppression of specific anti-tumor activity of the immune system, which is psychogenic and reversible. This creates real opportunities to control anti-tumor immunity, which largely depends on the course and outcome of the cancer process. Going back to the scheme of psychogenic carcinogenesis and the results obtained in the research, it becomes clear that mental disorders and the suppression of specific anti-tumor activity of the immune system are the clinical criteria and pathogenically significant links of the psychogenic carcinogenesis. In this regard, a very important issue arises. Why is there such a close relationship between higher nervous activity and specific anti-tumor activity of the immune system in cancer patients with a psychogenic carcinogenesis? The analysis of literature led to the conclusion about the existence of physiological inhibitions of specific anti-tumor immunity in the reparative process. This local inhibition is observed in the local tissue damage as a result of chemical, physical, or biological exposure. For the successful healing of tissue damage at the spot develops local inflammation with known cellular, cytokine, and vascular reactions. A key factor for successful tissue repair is a temporary local suppression of specific anti-tumor immunity in order to avoid the elimination of proliferating cells in the damaged tissue. After the completion of the repair process, the local inflammation reduces and the anti-tumor activity of the immune system restores. This natural physiological mechanism of tissue repair turns to become pathophysiological in psychogenic carcinogenesis. So as a result of the effects of chronic psycho-emotional stress in the body are constantly formed numerous foci of microdamages of different tissues. That leads to the formation of numerous foci of inflammation. Because of the large number of inflammatory lesions in the body, there is a constant imbalance of immune reactions in the direction of maintaining the reparative processes. This imbalance is accompanied by constant suppression of specific anti-tumor immunity. Under these conditions, tumor cells periodically appearing in the body are able to grow uncontrollably. While existing in the body, the tumor gets the possibility of generalization. It can be argued that higher nervous activity is the leading factor in the generalization of the cancer process in psychogenic carcinogenesis. Even in animal models, the leading role of the central nervous system for a generalization of cancer was shown. For example, Erica Sloan, with colleagues from Monash University in Melbourne, Australia, show a 30-fold increase in metastasis to distant tissues from a primary tumor in stressed mice. In general, presented pathophysiological processes in psychogenic carcinogenesis can be called cancer reparative trap, when the permanent tissue damage requires constant repair with appropriate suppression of an anti-tumor immunity. Any additional damage in the body of a cancer patient with psychogenic carcinogenesis, including surgery, chemotherapy, radiation therapy, enhances the phenomenon of cancer reparative trap. Elimination of mental disorders in cancer patients with psychogenic carcinogenesis releases the patient from cancer reparative trap by creating internal conditions for the cancer management and increasing the efficiency of standard cancer therapy. So, taking psychogenic carcinogenesis into consideration, the invention of effective anti-cancer drugs traditionally focused on the elimination of cellular, molecular, or genetic disorders is impossible. Financing of such extremely expensive but narrowly focused studies do not meet the requirements of modern clinical practices and holistic approaches to human cancer problems. Clinical practice shows that among cancer patients there are always those with frequent recurrences of cancer, resistant to anti-cancer therapy, rapid generalization of the cancer process, and common side effects of cancer treatment. Many of these cancer patients are likely to be affected by psychogenic carcinogenesis. For the successful treatment of such cancer patients, effective impact on higher nervous activity using an extensive variety of drug and non-drug options is necessary. Psychogenic factor is a major pathogenic factor in psychogenic carcinogenesis, which operates continuously at all stages of the cancer disease, unlike chemical, physical, and biological carcinogenesis. This is particularly important for clinical practice since it gives an opportunity to develop pathogenetically determined therapeutic, diagnostic, and rehabilitation practices. At the diagnostic stage, our proposed clinical criteria allows to define a group of cancer patients for whom a psychogenic factor has pathogenetic significance. At this stage, as well as in all subsequent stages of the cancer treatment, it is necessary to use an integrative oncology approach involving psychiatry and clinical psychology. At the therapeutic stage, the detection of mental disorders in cancer patients should be targeted and effectively eliminated along with providing the standard therapy of cancer. It is necessary to invent new combined drugs for standard cancer therapy with simultaneous exposure to the higher nervous activity in cancer patients. It is also necessary to develop new drugs and approaches to block the reparative focus of the immune system in cancer patients. Perhaps it will be the use of microdoses of cytotoxic drugs in combination with non-steroidal anti-inflammatory drugs and other drug combinations. At the stage of rehabilitation for this category of cancer patients, pathogenetically determined rehabilitation measures aimed at the preservation of mental health and anti-tumor activity of the immune system of cancer patients should be used. In this regard, we have developed and tested an anti-recurrence psychoimmunological rehabilitation of cancer patients with psychogenic carcinogenesis using a specially developed method of hypnotherapy and original immunological methods, epicutaneous and extracorporeal, activation of specific anti-tumor immunity. Details of the testing of psychoimmunological rehabilitation in advanced cancer patients are presented in our research work. Let's use the human brain in the global war against cancer in the 21st century. Thank you very much for your attention.